Okay.
Aspirant.
Yeah.
Our today's topic is the diabetic emergency, and we have our speaker with us, Dr. Payel Bose. As you all know, she's a very senior consultant at critical care medicine at Medica Super Specialty Hospital, Kolkata.
So, good evening, everyone. Without wasting much time, I would like to start the session because, as you know, it's quite a huge and elaborate discussion on the diabetic emergencies. Hypoglycemia incidence is around 40 to 60% in the critically ill patients. 28.6% patients are diabetic and 9.3% are non-diabetic patients. So this might sound like a very much enigma that non-diabetic patients even can develop hyperglycemia during the critical illnesses. So in the following slides, I would be discussing about these incidences in non-diabetic patients as well. And in the ICU patients, both hyper and hypoglycemia do occur, and this is associated with short and long term outcomes. Glycemic variability has also been found to be the predictor of mortality. Next slide. So, this is a pictorial representation, and as you can see, these are the various pathways of glucose metabolism. In glycolysis, metabolism of glucose molecule results in production of pyruvate or lactate for production of energy. Gluconeogenesis, here there is formation of glucose 6-phosphate from the non-carbohydrate sources like lactate, glycerol and amino acids. Glycogenolysis, here glycogen breaks down to glucose for production of energy. Glycogenesis, conversion of glucose to glycogen occurs, and this glycogen is directed towards storage. Lipogenesis, where the carbohydrates are converted to fatty acids. And de- fat decomposition occurs in cases of lipolysis. So, in the next slide, you would be looking, next slide, Arpit. Yeah. So, in the next slide, as you can see, the same mechanism is discussed in a pictorial fashion, and the hormones which are involved in regulation of blood glucose are as follows. Insulin and somatostatin reduces the level of the blood glucose. Epinephrine, cortisol, ACTH, growth hormone and thyroxine leads to increase in the blood glucose level. Next slide. As I was talking about stress hyperglycemia, in the critically ill patients, increase in the level of catecholamines, growth hormones, endogenous and exogenous glucocorticoids occur, along with increase in the level of the circulating cytokines and inflammatory mediators. Increase in insulin resistance causes inability of the skeletal muscles and adipocytes to absorb glucose by downregulation of the GLUT4 receptors. And increased adverse outcomes occur in patients with previous normal glucose homeostasis. So, this slide actually represents the stress hyperglycemia of critical illness. As you can see, cortisol, epinephrine, norepinephrine, glucagon, growth hormones are the stress hormones, and inflammatory cytokines like interleukin 1, interleukin 6, and tumor necrosis factor alpha leads to increased gluconeogenesis in the liver, proteolysis in the muscle, and lipolysis in the adipose tissue. And ultimately, all these three mechanisms lead to insulin resistance, which in turn leads to stress related hyperglycemia. And so, in the ICU, the diabetic patients may face diabetic or glycemic emergencies as well as the previously not known diabetic patients. They also face stress hyperglycemia or glycemic variability. Next slide. Now, this is the classification of diabetes mellitus, where you can see type 1 and type 2. Other than that, there's also hybrid forms, slowly evolving immune mediated diabetes of adults, which diabetics are very prone to develop ketosis. Other specific types of diabetes are monogenic diabetes because of monogenic defects of either beta cell function or monogenic defects in insulin action, diseases of the exocrine pancreas, endocrine disorders, drug or chemical induced diabetes mellitus, infection related diabetes, uncommon specific forms of immune mediated diabetes, and other genetic syndrome associated with diabetes. Other than these, the other classifications of diabetes are unclassified or idiopathic or cryptogenic diabetes and hyperglycemia detected for the first time in pregnancy or known precisely as gestational diabetes mellitus. So, next slide. Coming to the ADA criteria for the diagnosis of diabetes, HbA1c more than 6.5%, or fasting plasma glucose more than equal to 126 mg per deciliter. Fasting being defined as no calorie intake for at least 8 hours. A 2-hour plasma glucose more than equal to 200 mg per deciliter during an OGTT, that is oral glucose tolerance test. This test should be performed as described by WHO using a glucose load containing equivalent of 75 gram of anhydrous glucose dissolved in water, or in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose of more than equal to 200 milligram per deciliter. Next slide. Coming to the diagnosis, preference lies in the following order: arterial, more than venous, more than capillary. Why is it so? Because in critically ill patients, capillary values may be erroneous in patients with edema and shock. Continuous glucose monitoring definitely is the preferred version. 1 hour interval checking of CBG needs to be done in patients on infusion. And of course, HbA1c leads to the diagnosis of diabetes mellitus. Next slide. Coming to the recommended target blood glucose level for patients in the ICU, ADA says initiate insulin at less than equal to 180 mg per deciliter. Once insulin is started, a target glucose range of 140 to 180 mg per deciliter is recommended for most of the patients. However, more stringent targets may be appropriate for certain population, providing this lower target does not contribute to increased episodes of hypoglycemia or increased episodes of glycemic variability. According to American College of Endocrinology, here also the target blood glucose level is less than 180. The similar figure has been echoed in Surviving Sepsis campaign. SCCM, however, says the recommended target blood glucose in ICUs should be between 100 to 150 milligram per deciliter. So, next slide. So, what should be the dose of insulin infusion, or how do you calculate the ideal dose? Give initial bolus if blood glucose is more than 180. Divide initial blood glucose by 70 and round to the nearest zero point 0.5 units. So, for example, if blood glucose is 250, so 250 divided by 70 is equal to 3.57, rounded to 4, so IV bolus of 4 units. After bolus, you may start infusion at same hourly rate as bolus. If it is less than 180 mg per deciliter, divide by 70 for initial hourly rate with no bolus. So, if blood glucose is 150, the 150 by 70 value would be around 2.15 rounded to 2. So, start at 2 unit per hour IV. So, next slide is again the sliding scale of insulin level, not going into its details. Next slide, Arpit. So, blood glucose monitoring need to be done every hourly until the blood glucose becomes stable. Once stable, then you can change the monitoring frequency to 2 hourly. If stable, 2 hourly for 12 to 24 hours, you can change to 3 to 4 hourly if no significant change in nutritional status or clinical status is observed. Resume hourly blood glucose monitoring for blood glucose level more than 70 with any of the following. Number 1, change in insulin infusion rate. initiation or cessation of the corticosteroid or vasopressor therapy, significant change in clinical status, change in nutritional support, initiation or cessation of hemodialysis or CVVHD, hypoglycemia. If the blood glucose is less than 50, stop infusion, give 25 gram of dextrose 50%, that is 1 ampule of 5D IV. Recheck blood glucose after 10 to 15 minutes. If blood glucose is more than 90, recheck in 1 hour. If still more than 90 after 1 hour, resume insulin infusion at 50% of the most recent rate. But if it is between 50 to 70, then stop infusion. Next slide. Coming to subcutaneous insulin. So, how do you calculate? So, the average hourly insulin drip rate for the last 6 hours is, consider X units per hour. So multiply by 24 to give a daily usage rate of X into 24 units per day. Multiply this value
वही
by
चक्कर उक्कर
70
की
to
दवा हो नहीं भाई
85% to estimate the first day's total insulin dose. And all of this can be administered in divided doses twice daily. Glargine and detamir given once daily. Dosage adjustment might be required after the first given dose and henceforth should be reviewed daily. When the patients are able to eat, a rapid acting insulin like Lispro, Aspart, or Glulicin should be given prior to each meal. Some stable patients with type 2 diabetes can be managed with OHA, that is oral hypoglycemic agents or diet alone, but that therapeutic decision is best made after discharge from ICU to ward on a regimen of subcute insulin. Now, coming directly to the diabetic emergencies. Next slide, Arpit. The pathophysiology and pathogenesis of diabetic ketoacidosis. As you can see, reduced level of insulin leads to increase in the counter-regulatory hormones like cortisol, growth hormone, catecholamines, and glucagon, which in turn leads to reduced utilization of glucose, increased lipolysis, increased proteolysis, and increased glycogenolysis. Increased lipolysis increases the free fatty acid delivery to the liver, hence increases ketosis. Increased proteolysis leads to reduced protein synthesis and increased gluconeogenesis. So all these four mechanisms leads to hyperglycemia, and this leads to glycosuria as well as hyponatremia. So glycosuria leads to dehydration and hypovolemia. Hyperglycemia leads to hyponatremia. Why? Here, water shifts out from the cells, secondary to increased level of glucose or the osmotic load. So, as you know, every 3.5 unit increase in the level of glucose, there is reduction of sodium by 1 unit. Now, glycosuria in its turn leads to polyuria, and dehydration leads to hypovolemia, which stimulates the thirst receptors in the central nervous system, and hence the patient has got polydipsia. On the other hand, ketosis, that is generation of excessive ketone bodies, leads to ketoacidosis and lactic acidosis. And this ketoacidosis also leads to ketouria. On the other way around, dehydration also leads to hypoperfusion and hyperlactatemia and acidosis. So, hereby you can understand very well that the DKA triad of hyperglycemia, acidemia, ketonemia is also associated with hyponatremia, with dehydration, with polyuria, and polydipsia. So, next slide, please. Coming to HHS. HHS is hyperosmolar hyperglycemic status, previously known as hyperosmolar non-ketotic coma. So, here there is also impaired insulin secretion, gluconeogenesis, impaired glucose uptake, reduced glomerular filtration rate, impaired thirst mechanism, leading to hyperglycemia and hyperosmolality. Next slide, please. So, what are the precipitating factors of these diabetic emergencies? Inadequate insulin, infections, acute medical conditions like myocardial infarction, pancreatitis, CVA, interference with glucose metabolism or insulin secretion by some drugs like thiazide diuretics, corticosteroids, second generation atypical antipsychotics, tacrolimus, glucagon, and sympathomimetic agents like albuterol, terbutaline, and dobutamine. Endocrine disturbances leading to DKA and HHS are theochromocytoma, hypothyroidism, acromegaly, and hemochromatosis, which is also known as bronze diabetes. Substance abuse like cocaine and parenteral nutrition also leads to diabetic emergencies. Next slide, please. So, what are the symptoms? Next slide, Arpit. So, what are the symptoms of diabetic ketoacidosis? Vomiting, excessive thirst, signs of dehydration in the form of dry mouth and tongue, sore throat, dark circles under the eyes, deep heavy breathing, excessive urination, sudden weight loss, fruity smelling breath, complaints of abdominal pain, nausea, drowsiness, leading to unconsciousness. Next slide. Certain symptoms are typical of acidosis. Central symptoms like headache, sleepiness, confusion, loss of consciousness, coma. Muscular symptoms like seizures and generalized weakness, diarrhea, shortness of breath, coughing, arrhythmia, palpitation, nausea, vomiting, pain abdomen, of course. Next slide. The physical findings of diabetic ketoacidosis are dried buccal mucosa, shrunken eyeballs, poor skin tartar, tachycardia, hypotension leading to shock and poor peripheral perfusion, tachypnea, Kussmaul's respiration, abdominal tenderness, and CNS manifestations like lethargy, obtundation, cerebral edema, possibly coma. Next slide. Clinical features of HHS are insidious onset symptom, several weeks history of polyuria, weight loss, and poor oral intake, mental confusion with lethargy, focal neurological deficit, coma, absent nausea, vomiting, and pain abdomen. What are the signs? Next slide, please. Altered mental status, dehydration, hypotension or normotension in hypertensive patient, tachycardia, fever, or hypothermia. So, coming to the diagnosis, DKA, pH is less than 7.3, bicarb less than 18, it's high anion gap metabolic acidosis, glucose more than 250 mg per dl. However, euglycemic DKA is also an entity. Along with that, there is ketosis. So, how is ketosis measured? By sodium nitroprusside method, which detects only acetone and acetoacetate. Beta-hydroxybutyrate is the prominent ketone body in DKA, which is converted to acetoacetate as DKA is treated. In HHS, glucose is more than 600 mg per dl, osmolarity more than 320 milliosmoles per kg, and electrolytes, potassium, phosphorus, renal function, urinalysis also needs to be looked into in diabetic emergencies. So, next slide. Coming to the differentiating points between DKA and HHS. DKA commonly observed in type 1 diabetic patients, HHS in type 2. Ketosis acidosis, as is obvious from the nomenclature, is present in DKA, absent in HHS. DKA patients, there can be any age group starting from the extremes of age group, particularly young patients, they might also suffer from DKA, whereas HHS is typically present in elderly population. Onset of decay is rapid, whereas the onset is insidious in HHS. Nausea, vomiting, pain abdomen present in decay, whereas mental changes, focal neurological deficit, seizure-like CNS manifestations are more common in case of HHS. Prerenal azotemia is mild in decay, moderate in HHS. Blood glucose 250 to 600 in DKA, in HHS 800 to 1200, and the fluid deficit is much enhanced in HHS as compared to DKA, 3 to 5 liter versus 8 to 10 liter. Bicarb therapy is required in DKA, but after fluid resuscitation is done, bicarb therapy not at all required in HHS. Mortality, HHS, much higher mortality, around 15%, whereas in DKA, it is around 2 to 5%. Next slide. Coming to the diagnostic criteria for both, DKA can be divided into mild, moderate, and severe based upon the plasma glucose, pH, serum bicarbonate level, urine ketone, serum ketone, and effective serum osmolality and anion gap. Alteration in the sensorium or mental obtundation is mostly observed in HHS. Okay, so coming to the management of these diabetic emergencies. Next slide. IV fluid is the main cornerstone for management of these diabetic emergencies. Normal saline at the rate of 15 to 20 ml per kg over first 2 hours. Urine flow should be maintained at approximately 30 to 60 ml or 0.5 ml per kg per hour. Subsequent rate of fluid administration depends on the state of hydration, electrolytes, and assessment of the hemodynamic status. Definitely, dynamic measures of fluid responsiveness do help in guiding the fluid therapy. Deficit, as already has been mentioned, is far more increased and enhanced in HHS as compared to DKA. 50% correction needs to be done over the first 12 hours. However, we need also to note that excess volume of normal saline, which is an abnormal saline administration, leads to hyperchloremic metabolic acidosis. Hence, often in an intention to treat hagma of DKA, we create nagma, that is normal anion gap metabolic acidosis. So, sodium monitoring is very, very important along with chloride and pH monitoring during the fluid therapy in diabetic emergencies like DKA. And in hypernatremic and eunatremic patients, it's preferable to use half normal saline, that is 0.45% in ACL, or even balanced salt solution. Dextrose containing fluids needs to be initiated when the plasma glucose is around 200 to 250 milligram per deciliter. Next slide, coming to insulin. 0.1 unit per kg bolus followed by 0.1 unit per kg per hour. Target reduction of plasma glucose is at the rate of 50 to 75 milligram per deciliter per hour. If more and more amount of glucose is reduced and there is significant variability in the amount of glucose reduction, this leads to severe variability in the intracerebral pressure and might contribute to poorer outcome as well. So, insulin infusion needs to be titrated to maintain plasma glucose level at around 150 to 200 milligram per deciliter in cases of diabetic ketoacidosis and 250 to 300 milligram per deciliter in the case of HHS. Dextrose needs to be added to fluid when the plasma glucose level is around 150 to 200 mg per dl, that is less than 250. Hourly point of care glucose monitoring is mandatory. Subcutaneous regimen can be initiated when DKA and HHS is resolved, and there should be a significant overlapping at least for a period of 2 hours. Subcutaneous insulin therapy can be initiated once DKA and HHS is controlled and the patient is awake and able to eat. Half the total daily doses can be given as long acting insulin and other half as short acting insulin pre-meals. The patient should receive subcutaneous bolus insulin and rapid acting insulin along with the first meal and insulin infusion discontinued an hour later. Next slide. Insulin infusion. Next slide, Arpit. Yes, thank you. Insulin infusion must be initiated only when potassium is more than 3.3 MEq per liter. Potassium repletion when potassium is less than 5 MEq per liter, 20 MEq in each liter of fluid. So what should be the target potassium? 4 to 5 MEq per liter. So next slide. We need to establish adequate renal function. If potassium is less than 3.3, withhold insulin. 40 MEq potassium per hour till potassium is more than 3.3 MEq per liter. If potassium is between 3.3 to 5.3 MEq per liter, that is within the normal range, still you have to give 10 MEq of potassium per hour during insulin infusion for correction of diabetic emergencies, 20 to 30 MEq per liter of IV fluid till serum potassium is between 4 to 5 milliequivalent per liter. Do not give potassium if potassium level is more than 5.3, but please do check potassium every 2 hours because potassium, because of its intracellular shift, may deplete, go down while insulin infusion is ongoing, and this may lead to prolonged QT interval, Tossets points, and cardiac arrest. So, monitoring electrolyte level is very, very important during insulin infusion. Next slide. Phosphate therapy. Phosphate deficiency occurs because there is osmotic diuresis and also because of the intracellular shifting during insulin therapy. So, randomized control trials have not demonstrated that phosphate replacement is beneficial in DKA. However, if phosphate is less than 1 mg per deciliter, then there might be some adverse complications like respiratory depression, skeletal muscle weakness, hemolytic anemia, and cardiac dysfunction. So, next slide. Hence, routine replacement of phosphate is not recommended. Replace phosphate only when the value is less than 1 mg per deciliter. So, 5 ml single dose vial is equal to 22 millimole of potassium and 15 millimole of phosphate. And this vial is to be dissolved in 2 liter of half NS or 5D and infused at 400 ml per hour. So this will correct the phosphate deficit at 3 millimole per hour while providing 4.4 milliequivalent of potassium per hour. Okay, next slide. Bicarbonate. So there is no need for routine use of bicarbonate therapy for diabetic ketoacidosis because this can produce adverse effects like severe acute hypokalemia, late alkalosis due to paradoxical CSF acidosis, shift in the oxygen dissociation curve to left leading to tissue hypoxia and lactic acidosis, increased hepatic ketogenesis. Among children, bicarb therapy may lead to fluid overload and cerebral edema. So, when should bicarb replacement be used during the management of diabetic ketoacidosis? Only when hypotensive shock is unresponsive to rapid fluid replacement because this acidosis leads to myocardial depression as well. The buffering capability is completely exhausted. Respiratory responses or compensation are maximal. Acidemia is worsening, that is, pH is less than 6.9, and also there is advanced pre existing renal dysfunction. How do you give bicarb? 2 ampule of sodium bicarbonate, that is 100 MEq total, in 400 ml of sterile water with 20 MEq KCl should be infused over a period of 2 hours. Next slide. So, what are the other managements? General supportive care, ABC, airway protection, ventilation, identification and treatment of the stressors or the precipitating events. Next slide. So, begin fluid replacement of DKA and HHS prior to initiation of the insulin therapy. Studies have shown that hydration lowers plasma glucose by improvement in the glomerular filtration rate, renal perfusion pressure, and increase in the net urinary glucose loss. There is partial correction of pH and plasma bicarbonate with hydration. Low dose infusion of rapid acting insulin is recommended. Randomized control trials have shown lower rate of insulin infusion to be as effective as higher rates. Lower insulin rate confer reduced rates of hypokalemia and hypoglycemia. Potassium replacement should begin early. Studies have shown that insulin administration before volume and potassium repletion can cause shock and arrhythmias. Okay, so first fluid, then potassium. If the potassium level is low, then initiate insulin level. Next slide. Bicarbonate replacement is not recommended in managing diabetic ketoacidosis. As already has been mentioned, trials have shown no benefit of bicarb replacement in patients with pH more than 6.9 with respect to resolution of ketonemia, acidosis, or hyperglycemia. No trials of bicarb use in patients with pH less than 6.9 have been reported as well. Phosphate replacement has not been shown to be of benefit in DKA until and unless the level is less than 1. IV insulin infusion is preferred for moderate to severe DKA, whereas repeated doses of subcutaneous insulin may be used in cases of mild diabetic ketoacidosis. Next slide. So, the American Diabetic Association criteria for DKA resolution include blood glucose level less than 200 milligram per deciliter plus any two of the following. That is, bicarb more than equal to 15 MEq per liter or pH more than 7.3 or anion gap less than equal to 12 MEq per liter. Next slide. Resolution criteria for HHS are as follows. Serum osmolality less than 300 milliosmol per kg, hypovolemia corrected with urine output more than 0.5 ml per kg body weight per hour, return of the cognitive status or improvement in the mentation, blood glucose level less than 270 milligram per deciliter or 15 millimole per liter. Next slide. Now coming to certain special types of diabetic emergencies. Around 25 to 30% of diabetic ketoacidosis incidences develop in people with type 2 diabetes. Okay, they are referred to as the ketosis prone type 2 diabetes cases, mostly observed in Afro Caribbean or Hispanic descent population. Treatment remains the same, however, there is faster resolution of ketosis. Next slide. Euglycemic ketoacidosis. Here, there is raised anion gap metabolic acidosis, ketonemia, more than 3 millimole per liter, or ketonuria, more than equal to 2 plus in ketosticks test. History of diabetes mellitus, but glucose level is normal or not particularly raised. That is why it is known as the euglycemic DKA, especially observed in patients on SGLT2 inhibitors. Treatment, same as that in hyperglycemic ketoacidosis. Initiate 10% dextrose at 125 milliliter per hour as RBS is less than 250. Begin with 0.1 unit per kg per hour insulin and reduce insulin to 0.05 unit per kg per hour if RBS remains low to avoid hypoglycemia. Next slide. DKA in patients with CKD. So, the lack of renal insulin clearance means that ketoacidosis is much less likely to occur. It is difficult to diagnose because often CKD patients have associated chronic metabolic acidosis. Now, other diagnostic tests, that is lower beta hydroxybutyrate concentration and higher glucose and anion gap. Hypovolemia is not that severe in DKA patients with CKD. Why? Because here there is no urine and inability to develop osmotic diuresis. Treatment, insulin replacement. Here also, the fixed rate of insulin infusion is around 0.1 unit per kg per hour. Potassium supplementation is usually not required here because of the lack of osmotic diuresis. Next slide. Recurrent decay. That is, in certain population or patients, there are more than one episode of decay per year, which is quite frightening. 66% of these recurrent DKA is present in type 1 diabetes mellitus and 35% in type 2. Risk factors are fragmented care, social, behavioral, or psychological considerations, female sex, adolescence, lower socioeconomic status, previous history of admission to hospital due to ketoacidosis. And a recurrent DKA definitely is associated with increased risk of long term cognitive decline and premature mortality. Next slide. Complications. Electrolyte disturbances like hypokalemia and hyperkalemia, hypoglycemia, cerebral edema, hyperchloremic metabolic acidosis or NAGMA, fluid overload, acute kidney injury, venous thromboembolism, cardiomyopathy, rhabdomyolysis. Next slide. Prevention. Prevention of these diabetic emergencies mostly center around proper patient education. During illness or when oral intake is compromised, patients should frequently measure CBG, drink fluids to maintain hydration, continue or increase dose of insulin as per the CBG measurement, measure urinary ketone when serum glucose is more than 300 mg per deciliter. Of course, if he doesn't have access to keto sticks, he must seek medical attention because this might land him in life threatening medical emergencies. Next slide. Prognosis. Mostly, these diabetic emergencies tend to resolve in patients with proper treatment within 24 hours. Mortality rate is definitely less than 1%. However, in HHS, mortality percentage is higher, around 10 to 15%. Important causes of death among people under 58-year-old with type 1 diabetes mellitus definitely is diabetic ketoacidosis. So, what are the main cause of mortality? In children, cerebral edema, and in adults, severe hypokalemia, ARDS, and comorbid states which may have precipitated the ketoacidosis. Now, coming to hypoglycemic emergencies. So, how to define hypoglycemia? There is this Whipple's triad. What are the triad? A. Documentation of a low blood glucose concentration. B. Concurrent symptoms of hypoglycemia. And C. Resolution of symptoms after administration of glucose. Typically, less than 50 milligram per deciliter, that is 2.8 millimole per liter of blood glucose level characterizes hypoglycemia. The physiologic definition is a blood glucose concentration low enough to cause the release of counter-regulatory hormones, for example, catecholamines, and impairing the function of the central nervous system. This blood glucose threshold can, however, be variable in various patient population. Next slide. Classification of hypoglycemia in persons with known diabetes. Severe hypoglycemia requires assistance, recovery with carbohydrate with or without measured glucose. Documented symptomatic hypoglycemia, glucose is less than 70 mg per deciliter, typical symptoms are present. Asymptomatic hypoglycemia, glucose level less than 70 milligram per deciliter with no symptoms. Probable asymptomatic symptoms with no measured glucose level. Relative or pseudo hypoglycemia symptoms with measured glucose level more than 70 milligram per deciliter. So, next slide. What are the clinical manifestations of hypoglycemia? Hunger, tingling, shakiness, weakness, palpitations, anxiety. Diaphoresis, tachycardia, peripheral vasoconstriction, and widening of the pulse pressure. Early symptoms and signs of neuroglycopenia include altered vision or dimness of vision, difficulty in thinking, difficulty in cognition, attention span, and sensations of warmth, weakness, and fatigue. This may be followed by confusion, slurring of speech, and other non-specific behavioral changes. Severe neuroglycopenia can cause disturbances of integrative function, obtundation, seizures, coma, and rarely a permanent vegetative state. ECG abnormalities associated with hypoglycemia include T-wave flattening, increased QT interval ST segment depression, and repolarization abnormalities with bradycardia. Now, what are the causes leading to hypoglycemia? States of hormonal imbalances. Next slide, Arpit. Like excess insulin level, states of impaired endogenous glucose production, states in which gluconeogenic substrates are unavailable. Next slide. Hypoglycemia due to hormonal imbalance. Insulin overdose in diabetic patients. Intentional insulin and oral hypoglycemic agent overdose among non-diabetic patients, particularly in those with suicidal intent. Insulinoma, non-islet tumor that secrete insulin or have insulin-like activity. Necidoblastosis or PHH, that is persistent hyperinsulinemic hypoglycemia, antibody mediated, that is autoimmune hypoglycemia, pancreas and islet transplantation. Next slide. Hypoglycemia due to non-insulin hypoglycemic agents. Commonly implicated agents are sulfonylureas like glimepiride, glipizide, and glyburide. Other insulin secretagogues like natiglinide and repaglinide. Next slide. Now, if you consider the classes of the drugs, class 1 is insulin and analogs, class 2 sulfonylureas, class 3 meglitinides and biguanides, class 5 GLP-1 agonists like exenatide, class 6 DPP-4 inhibitors like saxagliptins, class 7 thiazolidinediones like pioglitazone, class 8 dual PPP-AR antagonists like saroglitazar, class 9 alpha glucosidase inhibitors like acarbose, class 10 amylin analogs like pramlintide, class 11 SGLT2 inhibitors like canagliflozins, which are implicated agents as well in euglycemic DKAs. Next slide. Now, this is an exhaustive list of certain other drugs and poisons that also cause hypoglycemia. Please go through these chart. Next slide. Various entities like liver damage, renal damage, and sepsis have been implicated as causes of hypoglycemia. Hepatic injury leads to hypoglycemia when the insult is very, very severe because only about 20% liver biosynthetic capability is needed to maintain normal glucose homeostasis. Hepatotoxins that can impair gluconeogenesis and cause hypoglycemia include carbon tetrachloride, Amanita phalloides mushroom toxin, and urethane. Drugs that cause hypoglycemia by inducing hepatocellular necrosis include acetaminophen, isoniazid, sodium valproate, methyl dopa tetracyclines, and halothane. Some patients with diabetes develop improved glucose tolerance with the onset of renal failure. Decrease in insulin requirements and more frequent episodes of hypoglycemia occurs as renal dysfunction progresses. Sepsis has occasionally been implicated as a cause of hypoglycemia. Shock and liver failure were intercurrent problems in some of the cases. Under conditions of reduced hepatic reserve, the combination of circulatory failure and impairment of gluconeogenesis by endotoxins may lead to hypoglycemia. Septic hypoglycemic patients are often acidotic and the fatality rate is very, very high. Next slide. So, what is the treatment of hypoglycemia? Bolus of 50 ml 50% dextrose followed by infusion of 5D or 10D should be started in any patient whose hypoglycemic episode is not clearly simply due to excess short or intermediate acting insulin. Hypoglycemia due to long acting insulin, continuation of the glucose infusion, fingerstick blood glucose testing, and periodic adjustments of the infusion rate. Hypoglycemia due to sulfonylureas. Activated charcoal absorbs sulfonylureas and urinary alkalinization may enhance excretion. Charcoal hemoperfusion is not indicated except in the setting of renal failure and massive overdose with sulfonylureas. Continuous IV glucose is required. Oral carbohydrate should be initiated when the patient can eat properly. Glucocorticoids are beneficial for those patients with hypoglycemia due to SARC, that is, critical illness related corticosteroid insufficiencies. Octreotide, which is the long-acting analog of somatostatin, can
Next slide.
inhibit sulfonylurea induced insulin secretion, and it has been used as a supplemental therapy for insulinomas. Oral agent induced hypoglycemia, quinine induced hypoglycemia in with the treatment of malaria, and reportedly in insulin glargine overdose where the mechanism of action is obscure. Doses 1 to 2 unit per kg body weight over a period of 8 hours. Glucagon diazoxide. Diazoxide is a benzodiazine non-diuretic antihypertensive agent that blocks the secretion of insulin from both normal and neoplastic beta cells to treat hypoglycemia. Diazoxide is infused as a dose of 300 milligram in 5% dextrose over 30 minutes every 4 hours or other infusion of 1 milligram per kg per hour. It has been reported to be effective in reversing severe refractory hypoglycemia due to sulfonylurea poisoning, non-insulinoma, pancreatogenous hypoglycemia syndrome, and neonatal hyperinsulinemic hypoglycemia due to certain gene mutation. Next slide. Suspect hypoglycemia in all cases of altered mental status. Be aware that intensive therapy with insulin infusion carries a risk of hypoglycemia. Always determine blood glucose concentration before administering glucose. Consider 10% dextrose rather than 50% dextrose. Why? Because 10% dextrose can be as efficacious as 50% dextrose while lessening the risk of subsequent hyperglycemia. Finger stick glucose concentration can at times be misleading, particularly in situations where glucose is being infused through the extremity and also in the settings of shock, CPR, and usage of parenteral nutrition product. Next slide. Suspect overdose of an anti-diabetic medication when unexplained hypoglycemia is encountered in the ICU. If hypoglycemia is thought to be due to a drug not used to treat diabetes, evaluate the case thoughtfully. When treating refractory hypoglycemia, always exclude adrenal insufficiency or SARC. The role of continuous glucose monitoring in the ICU is promising, but definitely costly and still investigational. So, that were the take home points in cases of hypoglycemias. Next slide. MCQ. So, a 58-year-old female presents to ER with complaints of pain, abdomen, fever, and vomiting of 3 days duration. She is a known patient of diabetes mellitus on metformin and empagliflozin. On examination, drowsy, dehydrated, tachycardic, tachypnic, hypotensive, oxygen saturation 94% in room air. RBS 235, urinary ketone 3 plus, pH 7.22, PCO 235, PO2 72 by cup 12. So, what's the most probable diagnosis? A. Starvation ketosis, DKA. C. Euglycemic ketoacidosis. D. HHS. What's the answer? Yes, very good. So, answer definitely is C. Next slide. Next one. Okay, thank you. So, all of the following are criteria for DKA resolution, except blood glucose less than 200, urine ketone less than 2, serum bicarb more than 15, anion gap less than 12. What's the answer? Yes, B is the right answer. Next slide. Next one. Okay. So, all of the following are features of HHS except serum ketone less than 3, serum osmolality more than 320, marked hyperglycemia more than 500, pH less than 7.3. Yes, of course. Firdaus, right answer. It's D. Next slide. Next one. Yeah. Okay. So, all of the following statements are true regarding HHS in comparison with DKA except A. Less common. B. May overlap with DKA. C. Associated with lesser mortality rate. D. Associated with more severe dehydration and electrolyte abnormalities. Of course, the answer is C. So that was all. Thank you. So, any
Thank you.
questions, anyone?
Aspirants, is there
Hello.
any questions? Then please ask. Ma'am, I
So,
think we don't have any questions right now.
don't have any questions? Okay. Thank you all then for your patient hearing and participation.
I have
So, good night to you all. Thank you.